Thank you very much. So, Günaydın. I am Samir Saeed. I lead the Connected Care and Healthcare Informatics for Philips in Middle East and Turkey. I am a doctor by training. I'm from Algeria, Jazair. And I'm very happy today to talk to you about what we do in healthcare digitalization, but also what are the promises in the future for artificial intelligence. The purpose of the talk today is to walk you through some of the challenges that some of the healthcare system is facing, but also with a zoom on in the critical care units and how we think we can help in preventing some of the issues, fixing some of the challenges, but also looking forward. As you know, Philips is, we look at healthcare through different angles, and we don't look at healthcare through diagnosis and treatment only, but we look at healthcare from the whole care continuum, whether it is from a healthy living with a prevention to the diagnosis, to the treatment, to the home care, and then discharge. What we think of is basically that the patient is not a disease, the patient is a journey, and through this journey we will enhance the patient journey, but also we will help the caregivers have a better view on their patient and putting the patient at the center. One thing that is extremely important is that some of the trends in the healthcare system that are affecting how the health system work is basically first the adoption of technology, and there was the first wave of the health IT 1.0, and then we moved to 2.0 with the deployment and implementation of EMRs. But there are some still some vivid issues within the healthcare system. One of them is the fact that we are mainly in our region, but also in a lot of regions, including Europe, the US, Asia, we are still a lot paper-based. And therefore, how do we ensure that going from a paper-based system to a fully digitalized system is something that will help not only the care for the patient, but also helps health authority to gather more information, more data, so they can have insightful decision making, so that they can invest the funds of the health system, of the healthcare system, into where it is needed most. The other thing is, we're moving into a highly connected world. It comes that with easier way of connecting with peers, doctors to doctors, doctors to nurses. It makes it easier to connect with patients, but also it makes it faster and less costly to basically provide the same level of quality healthcare. The downside of it is that you are in a situation where there is a lot of exchange of data, and therefore the security, and when the security is built from the beginning, is something actually that is extremely important, because there is one thing that is extremely precious, is the patient data, the health data of the patient. And we look at it from the built up, from a data security and privacy perspective. The other thing that we look at is, we cannot afford, no country can afford the soaring cost of healthcare. It's impossible to continue for one reason, is that you will have every single year more and more patients that will add up to the existing patient. And therefore the exponential increase of the number of patients will put a lot of strain into the healthcare system. The other thing is that from a clinician outcome, we need to be kind of transparent in the data that we share. And therefore, when you have more data that is digitized and not paper-based, because paper-based would be extremely difficult to manage or to read or to analyze, it's extremely important that this digitalization is not just for the sake of digital IT, it's for the sake of more transparency, and through multifaceted data analysis that could improve the awareness, whether it is from the patient perspective, but also from the authority. I mean, I'm thinking about ministries of health. How do they know that this hospital is working optimally, or this hospital through benchmarking can be improved. The final one is how do we ensure that while we gather this data, this data is used. Healthcare is the industry that produces the most data in the world. It is estimated that half the data that is produced every year in the world is data that is basically from healthcare. The problem is this data is scattered, and historically it has been like that because the health IT has been lagging behind in terms of IT adoption, because there were kind of a lot of pressure to change, but also the fact that there are habits, there are filing system, workflows, and so on. The problem is that all this data that is scattered, because the data exists even now. The data exists, probably on sometimes in digital form, but also on paper form, and it is data. And how do we ensure that this data is basically gathered, garnered, processed, so that we increase our knowledge and then we can predict a little bit what's going to happen? When you look at the ICU is probably the most costly part of the healthcare system, because it costs a lot of money, because patients need more attention, but also it kind of puts a strain on the health system, because these patients are critically ill, and we need to make sure that they not only receive the care that they need, but also we reduce the length of stay, because you cannot add more and more beds, and you cannot have caregivers that are intensivists. There is a huge intensivist scarcity and shortage in the world, and therefore, even if you add beds, you will not have enough people to manage those beds. In Turkey, in particular, and this is kind of a source of pride, you have an ecosystem of ICU beds that is probably one of the largest in the world. And this is very important because even in pandemic periods, like we are unfortunately living today, you still have the capacity to cater for those needs, and this is extremely important. The problem is when you have that big capacity, not only you need to ensure that it is used in an optimal way, it is used the best way, but also it costs less to manage actually those beds. The other problem that comes is that ICU within healthcare, as I told you, healthcare produces a huge amount of data. Within ICU, there's a huge, this is probably the largest amount of data that is produced. And as you see in the graph, before ICU and after ICU, within the ICU, it produces almost 10 times the amount of data per patient per day. It is estimated that you will have probably 1,200 data points per patient and per day. The problem is that when you start putting that on paper, it becomes very, very often not usable. But when you put it in a digital form, not only it feeds databases that can analyze those data, but also can start with algorithm, and I will talk a little bit about that at the end of my talk, about artificial intelligence, how you can make sense of all this data, where actually you can start to predict some deterioration or some patient going to a critical state. So these are the type of things that digitalization will help. And again, it's not about going fancy from paper to digital. It's really because it has a value. The other thing we look at is the increased demand in bed and the increased demand in clinicians' time. The most stressed function in the healthcare system in caregivers is intensivist. The problem is that nobody in the world has enough intensivists to cater for the needs that are coming. Why? The pandemic is one exceptional example, but you will have more and more people in need of that. Specifically, that we have now more chronic conditions than acute conditions. We have comorbidities where different chronic diseases are within the same patient, and therefore the need will continue to rise. And these are extreme challenges that we will have to face. So when you look at the different problems that we look at, we need to look at a complete documentation. Every patient has the right to have a complete documentation that can cater for his needs as it goes. And we need to improve efficiency. We need to reduce the pressure on the staff. We need to reduce the standard of care. It is not acceptable that in a hospital there is a standard of care, in another hospital 100 kilometers away you have different standard of care. We need as a country to have a standardized type of care so that everyone has is where it should be. But one thing that is extremely important is, how do we move from paper to paperless? Because this is where you optimize the patient care, and this is how it is supported. I gathered some information about Turkey in particular, and I found this article that has been published in the Turkish Journal of Anesthesiology and Reanimation last year, August in 2019. And I would like you to focus on two information here. One is that the existing beds that are kind of very sizable, I think it's more than 30,000 beds in whole Turkey, and it is kind of probably worldwide one of the largest. How do we ensure that those 30,000 beds, 30,000 plus beds are used effectively? And as you see at the beginning, in the results, there is an inappropriate use of ICU admission. 55% of ICU admission are inappropriate. Why? Because we do not have kind of a labeling of beds. We lack what we call the level 1 type of bed that can cater for not very serious need, all the way to level 2 and level 3. The other way is, how do we ensure that we have a better coordination between ICUs? And the only way to have a better coordination with ICU is to have this network of ICUs that are digitalized, and therefore this information flow can help all the units work together. And this is where you reduce the pressure on the system, but also you have a better view on every single patient wherever he is. And therefore, kind of how do we look at digitalization and how it works and how it helps? It reduces errors, medical errors. 66% of the medical errors in AICU are man-made, not because they are not the caregivers are not good, but just because at a certain point the amount of data that is coming, can put an unneeded stress on all those caregivers, whether these are nurses or intensivist doctors. The other thing is that how do we ensure that this digitization will help the efficiency and access to care? As you saw in the previous slide, you have kind of half the admissions in level 2 and level 3 should be in level 1, and therefore you are using a bed that is probably more expensive to manage for someone who is not supposed to be there. The other thing is how do we ensure the improved clinical outcome? The fact that you digitize your ICU helps you get a clear view on all what's going on from the admission of the patient, but also you can upload what happened in the last 24 hours, in the last 48 hours, and also you can discharge the patient more rapidly so that you free bed and you continue after the discharge. Of course, you improve your financial outcomes, because at a certain, if you optimize the use of the beds, this is where actually you reduce the cost. The other thing is, this is innovation, and innovation doesn't mean that you bring fancy screens into the hospital. Innovation is how do you manage this ecosystem within the ICU the best way, so you optimize also your workflows. Things take less time to be done. The problem in EICU is that there are a lot of errors, and these are errors not because people want to make errors. It's just that at a certain point there are serious errors that can affect the patient, and this is because the safety is not optimized, because they are completely overwhelmed with patients, with all this data that I talked about, and all those critical decisions that every single intensivist or nurse in critical care needs to take in a very short amount of time. All up to 78% of serious medical errors happen in the ICU, and therefore, how do we ensure that we cater for those needs by the fact that you will have automated system that will help you manage better the patient flow, the workflow, the clinical workflows, as well as the decision, the discharge decision that the system can help you do. So what do we aim at? We need to reduce the documentation, because this takes a lot of time. Just to give you a perspective, a doctor on average worldwide spends roughly 40% of his or her time filling papers, filling documentation, and this is something that is taken out of the real care that they need to provide. The other thing is that you have the diminution or improvement in the stress level and the workload on physician reduces the churn-out. You have this is probably in the world of medical care, the doctors that are more inclined to actually leave their practice within a hospital are intensivists, because it's really taking a toll on them. The other thing is, then how do we ensure that we're not putting a system just for the sake of the system? We need to measure what the system brings in terms of saving budgets and saving costs. And this is where the clinical decision support gets in. This is where all this data that you gather will start to make sense to the system, because it starts to predict outcomes. It can detect small things that on paper-based there is absolutely no way you can discover them, but the system constantly processes and churns data so that it gives you early warning, early detection of deterioration. You can manage your triage so that every patient goes to the right bed instead of going to a bed that might not be him. And also you can benchmark different hospitals so that everyone has kind of a level, a target for improvement, and therefore we improve the health system and the healthcare provision and the healthcare delivery in the country. And these are some examples. These are the clinical outcomes that we look at. Reducing the length of stay. It costs a lot of money to stay in an ICU unit. It's extremely costly. The more you stay, the more you will have risk of error being done. The more you stay, you will increase your comorbidities. It's important to know that hospital in general is a cause for hospital-borne diseases, infections, and so on, nosocomial infections. But the more you stay, the more you increase the risk for those patients that usually have comorbidities, that are elderly, to actually catch something that they did not have before getting into the ICU. So how do we look at it? We look at it from the digitalization first. We look at it, the digitalization will bring digital transformation, and ultimately the clinical transformation. What I mean by that, and again, I'm a medical doctor by training. I worked in IT as well. Digitalization for digitalization is not attractive, because you move from paper to laptop. Okay, so what? It's important because it brings a new way of doing things, a new optimal way of doing things, that will lead to clinical workflows and clinical protocols that are modern, that are different from a clinical protocol that we were used to in the paper-based. I used to work on paper-based all my career, before I moved, and it's very difficult when you have a patient that has chronic condition, for example, that comes back to a hospital. You need to go to the paper locker, look at the file, try to find what happens. Whereas when you digitally transform, this is where your clinical work becomes more meaningful for the patient, but also for the entirety of the health system. And it's important because it enforces clinical best practices, protocols. It saves time. It meets national standards. I know that Turkey has very high national standards when it comes to performance in healthcare. But also, how do we ensure that we track this performance? How we reduce the complications? How we increase the compliance, reduce errors, adverse drug events? All of this is not possible, or is not possible optimally, if you have a paper-based system. And we look at it from connecting the care across the continuum, from the bedside, away from the bedside, all the way to the nurses and doctors' workstation, at the unit side. You can look at it from the hospital perspective, where every single interaction with the patient is logged and traceable, and you can look at it at any given point in time, all the way to basically having your system on your mobile that you can access from anywhere. So what do we do? What do we do with IntelliSpace Critical Care and Anesthesia, what I call ICA? It's important to look at, imagine a healthcare setting, an ICU setting, where you have, I don't know, 10, 15 beds. On average in Turkey, I looked at the numbers. On average, an intensivist has 2 to 4 patients a day that he needs to look at during daytime. The problem that happens is that during nighttime, the ratio goes to 1 to 8, just because people need to get home, people need to rest, and you don't have a pool of anesthetists that is infinite. You have a pool of intensivists that you need to work on. So, and this is what we've seen everywhere in the world. You have more problems that are happening during the night because you have less people to cater for those needs than during the day where you have all the team there. And this is important because then we can think of how do we ensure that, regardless of the time of the day, the same care is provided to the patient. I can give you an example that we did, between a center in the US, in Atlanta, Georgia, and another center in Australia, where the doctors in Georgia during the day take care of the patients in Australia during the night because it's night there, and the other way around, when Georgia goes to night, Australia is the day. So this is how we can look at it. And I understand that in Turkey, it's the same time zone and so on. However, you can think of it as where a doctor is less used somewhere, he can help somewhere else. And therefore, kind of you create this kind of cross-pollination of skills within the network. What is it from our perspective? All aspects of the patient need to be in one single place. And this is kind of the philosophy of it. ICU patients, because they account for the highest cost, how do we ensure that we have a strategy where all data that is coming from a patient, from any system, any medical device that is connected to ICA, actually provide one single version of the truth of every patient at any given point in time. And it's extremely important because, again, if you remember, I started my talk talking about the patient journey. At any point, the patient needs to be sure, and the doctor needs to be sure that the data that is in front of him is the latest data available. In paper, it's a little bit challenging, and therefore, kind of how do we ensure that we can have this data in one place, because then you can prevent complications, you can improve your interdisciplinary work and communication and planning. You can plan for your bed availability. When is the next bed coming? Because you know the length of stay and you know when you have to discharge. All of these informations are extremely important because you acquire the data, you analyze the data, and then you take proactive decision because you have a decision support and analysis that help you decide what to do next. And from our perspective, this is something that we're very proud of. We are installed in more than 40 countries. It's available in 17 languages, including Turkish. So these are where we create this network of knowledge and skills, where actually a doctor in Turkey can also be in contact with doctors elsewhere to exchange information, best practices, patient flow, clinical flow, scoring data. These are the type of things that we see as kind of the next step of the bed digitalization. And you look at it from the perspective of the intensive care unit, all those machines, the operating theater, this is how we look at it. And we need to move from this type of patient sheet to something that is really actionable. So this is the physician view. The physician view where actually you see everything that is related to the patient himself. And what I mean by the patient himself, it's not the medical history, is everything that is being done to this patient at any given point in time. So the patient history, the summary of the patient, what are the hemodynamics, what are the vital signs, how the nutrition facts, the inputs and the outputs. So all the intakes and the outputs, all of this information in one single view, in one single screen. One thing that is also of a challenge in ICU is that the flow of information, and when you have a lot of information, a lot of sheets, you cannot focus on something else because there is a lot of information, and we do it in a way where every screen will give you the information that you look for, and therefore it's not a screen with 1,000 screen where you need to scroll through 1,000 screen to find the information. The information that you look for is immediately available, and this is how the physician looks at it, the patient history, the summary and the discharge, the daily assessment score, the order management for drugs. So this is where the decision is taken, and it is immediately transferred into the nurse workflow, and she has the history. If she has the right, the system will recognize this nurse has the right to access this type of information. The work list, all the things that this nurse needs to do, the care plan that has been decided by the doctor, and even the daily notes. And when you look at the daily notes, it's important to look at it from the link to something else. So it's not just automated things, but you can also attach notes, and you can also when you look at this, you can also attach pictures, attach X-rays, MRIs, and so on. So these are the type of things where actually it becomes a comprehensive view of the patient at any given point in time. The other thing is we look at it from what are the components, because it's important for the caregivers and for the nurses to understand what's in it for there. If you remember in the arrow, digitalization is something, digital transformation is something else, clinical transformation is something else. Unless the caregivers have clarity on what's in it for them, it's very difficult to have a compliance within the system. And therefore we look at it from the patient census and dashboards. We can customize flow sheets that are in line with your own flow sheets, the care team documentation. We integrate with the operating room, with surgery. There is a calculation engine that calculates automatically the intakes, the output for urines. This is important as well in ICU, but also the scorings, all the scorings that you can put there. You can capture images. You can bring an image from the PACS. You can bring images from the wrist. So all of these are kind of aggregating all this information, so that every time you look for a patient, you have one single version of the truth. And you can also have remote access if you are in intensivist, because you can be called when you are outside of the hospital, because we need you. And therefore you can access the ICA anywhere on your mobile app, so that also you can take an informed decision and actually counsel for the decision to be made. And we support HL7, which is extremely important, because then you can have kind of a flow of information that is secure, but also that is within the standards that we require in healthcare. So I've shown that this is important to look at. The ICA sits at the middle, and everything that kind of feeds it, whether it is the devices that are in the hospital, the analyzers, the modalities, MRI, CT scans, and so on, feeds the PACS, the radiology information system, the lab system feeds in, and even connects to an EMR if it exists. And it's important because when you look at it, and this is what has brought a little bit of lagging behind in healthcare. That's why health IT has taken more time than, say, the airlines or finance. If I ask you when was the last time you actually went to a travel agency to buy a ticket, you probably don't remember, because everyone feels normal now to buy it online. In health IT, it took a little bit more time. Why? Because of this. Because every system is actually independent from the other system, and therefore these silos are very difficult to connect. And this is where we put ICA at the center, where actually it connects through our business engine. It connects all this data, and to make it visible, viewable, actionable at any given point in time. So this is the new world dynamic. It's a new approach. How we look at the data coming from different sites, different sources, and aggregate them into one single view. And this is where the more data you produce, the more artificial intelligence proactivity you can bring. I know it's a buzzword. Everyone is talking about artificial intelligence. It has a promise, but it's important. It's important because of three things. The first thing is that the notion that it replaces humans is wrong, because actually it augments the capacity of the humans. I'm the first one to say medicine is an art. It's not a science. You need this human interaction. However, spending 40% of your time or 60% of your time just doing redundant administrative work is not the best use of your time. The other thing is the shortage in caregivers worldwide. We estimate that we have anywhere between 1.5 to 2 million doctors that are in shortage worldwide. It's a lot, and you cannot just click your finger and have a doctor. It needs time. It needs 6 years to get a general medicine doctor, and it needs 4 or 5 years to get a specialist. It takes time. You cannot compress this time, and therefore, with the pressure that is coming on the system, it's important to basically remove everything that is redundant, let the system work on them, and give you the information that is important for the doctor to take a decision. If you remember this slide, I was telling you about the data that is produced every day. This is 1,200 data points per patient per day. It is absolutely impossible for any human being to process this amount of data for patient in one go. It's impossible. And therefore these data, and this excludes the vital signs. So it's not even, your heart rate, this is not even included in that. So at a certain point, we need also to relieve the caregivers and the system from, trying to spend time on these things that the system actually could read for them. And this is where we look at fostering the connected care and the collaborative care across setting for the doctors. And it goes from hospital to home, because in this article of the Turkish Society of Anesthesiology and Reanimation, it states that actually 35% of the ICU beds are used for palliative care, that actually patients are there just because we don't know where to put them. The second thing is that 68% of those patients could be discharged and could be taken home. The problem is that I understand the families, when you have, someone who is elderly, palliative care, they don't know what to do, if you bring the patient home. So they leave them in the hospital because this is where they will receive the best care. And this is where the from hospital to home makes a lot of sense. And this is where we look at it from the software perspective as well, because you will have also software and devices that the patient can have at home that can monitor him as well and feed the system. And every time the patient is in a situation that requires the intervention of the caregiver, then the caregiver intervenes. Otherwise, just the system, will continuously monitor this patient without having to put this patient in a hospital and actually occupy a bed. And this is where these are numbers that we look at, reducing the readmission rates by 24%, a quarter of a readmission rate reduced. It's extremely important. It's a lot of time, a lot of beds, and a lot of money. It reduces the mortality because the system constantly monitors for deterioration signs. So it can tell you this patient in the next 12 hours, 24 hours can deteriorate. So you need to take actions right now. The other thing is that you reduce the number of adverse events because the system reads when something is going wrong, whether it is fever, whether it is an increase in heart rate, whether it is an increase in respiratory rate, the skin temperature, the skin sweat, all of these things can be monitored remotely. And this is where we look at it if you remember the first slide, the whole care continuum. We do not focus on what costs a lot of money, which is the diagnosis and treatment, but we also the home care is one component that complements the whole healthcare system. And detecting early signs of a patient is extremely important, because the late detection of any patient deterioration will lead to transfer. And it leads to a slow transfer, because by the time someone who is not doctor in home might not see it as seriously as a doctor. And this is why the system constantly monitors and gives immediate warnings. But this requires an ecosystem. Having a fancy device attached to a patient chest is not something that makes it reliable. It's the whole ecosystem. What happens if the patch discovers that the patient has a heart rate that is going up? What does this happen? What does this mean? So the whole ecosystem means that it feeds back the system in the hospital. If there is something that can be done remotely, talking or giving advice, we can do it. But if there is something that is serious, it triggers an automated system, because I know that in Turkey you have an ambulance system that is one of the actually honestly the best I've seen worldwide, where actually every patient is anywhere between 4 to 8 minutes from an ambulance. And then if you link all this to the ambulance system, where actually if there is a deterioration, the nurse at the center can trigger a button, and immediately the ambulance can go home and pick the patient and start the treatment right there, because inside the ambulance you're still connected to the hospital system. And this is how we look at it. We look at it honestly from kind of almost a command center type of things. This is eCare Manager. This is after you digitize your bed, this is kind of the next step. Again, this is where I talk about digitalization, digital transformation. And again, we need to take it in a phased approach. Nothing can be done immediately for everyone. We need to look at it, let's digitize, let's move from paper to paperless. Let's look at the digital transformation that is needed, what is the ecosystem that needs to be done, and then the clinical transformation, the way care is delivered. We as Philips, there are more than 6 million people have been monitored by our tele ICU systems. It's a lot, and this gives us a lot of knowledge, and this is where we use our knowledge. Our EICU Research Institute is available to all our customers. They can look at, this is the largest database of ICU stayed in the world, and there is no match to it. And this is something that all our customers and caregivers can access to do research, to look for best practices, to look for advice, to connect with other research institute. But also it helps, because it's massive in terms of data that is there. It helps also build new algorithms. So we can partner with the Ministry of Health in Turkey, or the Society of Anesthesiology and Reanimation. We can look at the scientific societies to partner on building algorithms that are specific to Turkey, that can be used in Turkey, but that can be also exported elsewhere, because there is this amount of data that is available. So you can do it independently, you can do it just for Turkey. So these are the type of conversation that we need to have. But in any way, for us, the long-term knowledge and experience needs to address this wide range of the issues. The patient journey, the caregiver workload, but also the system, how the system will cope with the increased demand and actually reduce cost, but not reducing the quality of care. Thank you very much. Thank you for your time. And if there are any questions, I'm very happy to answer.